Hi, everybody. Welcome back to another episode of Brush with Brit. Today, I have Marvelyn here. Marvelyn, thank you so much for being on the podcast today. I'm so excited to have you here and learn more about the Perio microscope. And so I think I wanted to just start today off just by kind of describing what that is. I have a lot of students that listen to the podcast and have no idea what a perio endoscope is. So I would love for you to just kind of start with describing that if you can.
Perfect. Well, thank you for having me first and foremost. This is a big passion of mine, and I would love for students and just everyone to know about this because I do feel this could be standard of care one day. And if not, it should be. So, the technology has actually been around for about 20 years, and not many know about it. But why not? If you have the ability to have subgingival superpowers and subgingival vision and not be able to guess if you got all the calculus off or not, why wouldn't you want to do that? It's available to us. But what it is a small fiber optic camera. It's smaller than a ballpoint pen. What we do is we insert it subgingivally and we can then see it in real time focus, the root surface visualized on a screen. And the endoscope has the capability to go up to 15 millimeter pocketing. So it just takes guessing out of the equation. You can actually perform a visual periodontal therapy appointment, visual scaling and root planing procedure. So you can thoroughly remove all the calculus and you will have more of a predictable result for that patient. It definitely does take acquired skill, and you're looking at the screen the entire time versus the patient's mouth. So, ergonomically speaking, you actually are positioned better because you're in an upright position with both hands looking at the screen instead of when we're going and doing a lot of motions when we're working on our patients. And 2 feet, so in your non dominant foot or whichever foot, you would actually be controlling the endoscope. It has water flow, so it can help us prevent a lot of that blood or hemostasis that we're seeing in the camera, water flow. And then in your dominant foot or whichever foot you wanted to work with, you would power your ultrasonic, Camtron piezo that you're using. And we only use powered instrumentation. So we actually don't even use our instruments to scale while doing this.
So, what kind of training do you have to go through in order to practice with this?
So you do have to have an in-person training. My training was about 8 hours long, and I had two patients, which the first patient, what I will say is an earlier periodontitis patient with maybe 5 to 6 millimeter pocketing with some light clicks. That way you can get comfortable in a shallower pocket depth. And then my second patient was actually 7 millimeters and above. So I got to actually train on a deeper pocket and see what that was like. And they say, rule of thumb, it really takes you about 50 to 75 quads to actually become proficient in this skill. I like to compare it as playing a video game. You're trying to learn how to operate your control and learn how the game works and actually beat the game. So it is a learning curve just because you are using both hands, both feet, and it's hard. There was days I wanted to run out for the hills. I was like, this is exhausting, not only mentally, but taxing. But I stuck with it. And now I'm so glad I did because the results are phenomenal.
I think it's like that with a lot of things as hygienists. Like, there's new stuff that comes out, and it's never easy to just grasp onto the newest technology. But once you like force yourself to kind of embrace those aches and pains through learning, then you get to a point where you become more confident with it, and eventually it gets easier. Like, I always think of it as like the first time I used a probe. Like, that was so hard,
It
you know?
was.
And now it's like you can basically like almost use it with your eyes closed, like it gets a lot easier. I know that you are using this in kind of a different way, I guess, as a hygienist, and you're getting into dental offices a little bit differently than traditional clinical hygienists. So I would love if you would share kind of how you are utilizing this amazing skill.
So now that I've been doing it close to 10 years, I am very proficient in it. I don't have to second guess myself. And I did want to bring out one point too. So when you are holding the Explorer, think about it as it being your mirror, but in the mouth. So basically, your Explorer in your non dominant hand will be your mirror, actually your camera. And then in your dominant hand, you would hold the actual ultrasonic or powered insert to help you do what you need to do. So, just as it took time to learn how to use your mirror and indirect vision, this will also take that time, but it's extremely worth it. And to your point, I am doing this a little bit different alongside with my partner, Katie Benavides, here in Nevada, Las Vegas to be precise. She has also been using the technology for about 10 years. Her and I didn't even know about one another, but we were introduced by a local rep. We met for coffee and we said, we have to do something different. We're so passionate about what we're doing. Not many people know about this. So let's make a business model. Let's do something outside the box. So her and I both went in and we bought an endoscope. They're pricier, but as a hygienist, sometimes we have to go beg our doctors to get things for us, but we took a different approach and we bought it for ourselves. So her and I did that and we created a business model where even though we are not allowed to practice with much autonomy here in Nevada, we are still performing under the regulations and the laws with under supervision of a dentist. So we now partner with dentists with our endoscope. So we are almost like traveling periodontal hygienist specialists, and we bring our endoscope to them. So their patients do not have to leave the comfort of their dental home, go to a specialist. I mean, statistics show that a lot of the time when you refer a patient to a specialist, 50% of the time they go. And if they do, it's probably too expensive or they're not sure or they don't trust the person or whatever the barriers may be. So this keeps the patient in the comfort of their own home. The doctor actually gets to keep that revenue in house and treat more earlier to moderate cases of periodontal disease without surgical intervention. So they have loved it. We're in year 2 and we have about 20 partners and we're still growing every day. So it's been an amazing journey just going from a hygienist in the op to now entrepreneur and doing your own thing and practicing more independently as a hygienist.
Seeing you guys do that is really inspiring. I think it's an innovative way. And like you said, like thinking out of the box of how you can utilize this skill. And something I didn't think about until I saw you. And I'm like, oh, this is really interesting. I'm like, wait a second. She's kind of like going to different dental offices, bringing the equipment with you. A few questions. Can you give a range of about how much the machine does cost just for the listeners if they're curious?
So there is an older unit that was $19,000, but unfortunately they stopped manufacturing that one. That one came out in earlier 2000. So they stopped manufacturing, but they're still selling the disposables and so forth. We actually now own 2 units, so we have both. But we have the older unit and we have the newer unit, which is closer to $40,000 actually, and that's the one we actually purchased.
Okay. And then when you are going into a dental office, how many patients do you see per day? Or like, how does that process work?
We usually block out about 4 hours per patient because we don't know if their calculus is going to be tenacious or how long it's going to take us, especially if the patient has anxieties or so forth. So we block out 4 hours for the entire mouth. So usually we're seeing 1 to 2 patients depending on the office workflow of the day. So we do want 4 hours per patient. So we're as thorough as we can and we allot the time for anesthetic and breaks and so forth.
And I know you mentioned that the office is then able to keep the revenue in house. Is there a charge for using this technology for that case?
There is. So unfortunately, there's no procedure code for endoscopes as of now. They tried to push it in the past twice, and for some reason, they refused to give it a code. I will say it can range anywhere depending on the office and the discretion of the doctor can range anywhere from 2,500 for the full mouth to 5,000. But when you put that in perspective in comparison with periodontal flap surgery can be anywhere from 8 to 10K plus. Not only that, but the patient will have downtime and it's surgical. They need anesthesia. So there's a lot that goes into that. So when you're now telling the patient, we have a non surgical, minimally invasive approach that's less costly, but you get the same results, they are more likely to go forward with the treatment.
And are you bringing them back for like when you do like NSPT or non-surgical periodontal therapy? Sometimes there should be that like 4 to 6 week reevaluation. Is that how you go in the steps of their post-op care?
So, because we do go deeper with the endoscope and we are, in essence, flapping back the tissue non surgically or retracting it, it does take time for that reattachment of the ligament. So, we're actually telling the offices that we don't want them probing for about 6 months to not disturb that attachment and healing. Now, it does really depend on the office flow and the philosophy if they did want to do that 6 week recare just to look at tissue. Some offices are doing it and some are not. I mean, there's also back and forth research with that, even with periodontists, right? They're saying that the 6 week can be just maybe for oral hygiene modification, but really you see true healing 12 weeks and up just with that reattachment and healing. So that's why we have to just give it a little bit more time. And even though we may be getting a probe depth initially, say it was a 6 or a 7, but once you're in there with the camera and you can see where the calculus and remove it, I always probe afterwards. And that pocket gets even deeper because we were hitting calculus or
Mhm.
we weren't getting the right angle or wherever the calculus was located. So it does get a lot deeper. So you do see more damage that was present that was necessarily assessed to begin with. And that's out of our control. We do the best with what we can.
And then they're generally coming back for, like, a periodontal maintenance cleaning after that?
We personally don't go and do the recare. That would be the office that they would do the maintenance. But 2 years we've been doing this and we have not heard any complaints and just the results are amazing. We have had dentists text us and say, this is like having surgery without having surgery. So they're mind blown.
It's super interesting because I haven't had any experience with it at all, but what I have had experience with is referring a patient to perio, and then they end up having osteosurgery, and they come back, and I'm, like, literally mind blown by the result of it, so I feel like that's kind of the same feeling I would get with this.
Yes, and we have now even delved into with some of the offices we're partnering with. We as hygienists, we actually can't place this, but it's called biologics. It's a biologic protein material that helps regenerate bone and also attachment loss. And for that, the results can be available within 9 to 12 months. And we've now been seeing those 9 to 12-month cases. And where there were severe bony defects, we went in there and cleaned everything off with the endoscope, clean root surface. Then the doctor comes in and place that biologic material localized in those sites. And there is regeneration of bone. So we are now seeing regeneration of bone without surgery.
Wow, that's incredible. I did have a question about the scope of practice for hygienists because I know you said, you're getting all the way down into their pockets. Is there any like gray areas? And I know you mentioned you're in Nevada as far as like the scope of practice for hygienists using this technology. Hey friends, quick little break here. If you're enjoying this conversation and you'd love to bring Brush with Brit to your next event or your school, I'm now booking speaking events and meet and greets for next year, and I would love to add your location to the list. You can learn more at brushwithbrit.com. And if you're a student, definitely click the For Students tab. That's where you're going to find resources, career tips, and tools to help you thrive in your new role as a dental hygienist. Now let's get back to the show.
No, because we're basically just performing a visual scaling and root planing procedure and assisted with an endoscopic camera. So there's really no gray area. So my mentor actually did this when this technology actually came out. Unfortunately, she passed away. However, she tried doing what we were doing about 20 years ago. But I just feel technology wasn't where it was now. So it wasn't the time. I think a dentist was feeling some kind of way that she was kind of doing what we were doing. And he brought it to the board. And there was a board case and meeting about it. And they said she really wasn't doing anything wrong and she was allowed to do it. So there is really no gray area. And we have that to back it as well.
What about like adjunct services in addition to using the perio endoscope?
There's so many that you can use. There's some offices that love to do lasers or they have GBT. So they have a whole protocol that we'll do. We'll do the biofilm removal first, then we'll perform the endoscopic visual SRP, and then we'll go laser at the end. Or I love personally using Perio DT because it softens the calculus. It's that desiccation technology. So it just makes it so much easier for myself and the patient. It also clears the visual field with hemostasis. So it's a great adjunct as well. So really just depends on what you have available to you and what you want to utilize in conjunction with it.
Okay, so when you go into the office, then you're just kind of utilizing whatever additional adjunct services they have.
We bring our own Cavitron, we bring all of our own tips. We purchase all that ourselves because we want the best of the best. And I bring also my own Perio DT.
Yeah, I've been hearing really good stuff about the Perio DT. Still waiting to try it, but I just got some in the mail, and so I'm excited to
Yay!
use it. Because when I posted about it, everybody's like, "Oh, that stuff is so great! Like, it makes
It's
such a
amazing.
difference." So, is that something you're using pretty regularly with the endoscope?
Yes, especially in heavier cases because the calculus is heavier and the hemostasis and just the granulation disease tissue. It just really almost cauterizes the area for you, removes that necrotic tissue. So it's not in my visual field hanging out, waving at me, all that tissue. And it just makes it so much easier.
How do you feel using this technology has changed your perspective as a hygienist as far as like perio?
I will say that tooth anatomy really makes more sense now. I think when you are a student and you're learning all about anatomy in your anatomy class, they have you drawing out the tooth, shading them out. You're really not thinking of it the way I think of it now. Of course, we're just trying to survive and graduate also, but now it really just clicks. I look at furcations differently, distal line angles differently because you can actually visualize it. So now I created even a whole presentation around just instrumentation because now it also makes you review anatomy, but also learn the specifications of your instruments. When do we really sit down and look at what kind of instruments we're working with in the operatory? A lot of us just use the same ones. I remember when I just graduated, I was like, I love my 5/6 universal, I love my sickle, and I love my straight cavitron, right? But now visually, as I am using different tips, they don't access every single area. So if you don't know the specifications of your instruments, you're going to be missing calculus. A 5/6 is not going to access an 8 millimeter pocket. Is it an extended shank that will help me adapt and reach to the distal line angle of that 7 millimeter pocket? What can I use that will really adapt and access for what I need my instrument to do? So it just makes you think about instrumentation differently. And not only that, but periodontal disease and calculus. Because if we're not using the right tools, you are already missing half the battle with disease.
That's the other thing I wanted to talk about was missing calculus because I understand the importance of emphasizing that in dental hygiene school. You know, you're taught you get every single piece off and you don't miss a piece, right? And then like you get into the real world and like you have the hardest time with the piece of calculus and you're like, "Oh my gosh, you know, what do I do?" So I think it's just important for us to talk about that we do miss calculus. I'm not saying we should miss calculus on every single patient or anything like that, but it does happen. And I feel like something like the endoscope would help to teach you the areas that you're missing and even like what some things feel like. You know, we're
Mhm.
going around feeling all this stuff, but I feel like if you could see it, it would help you understand, oh, that's what I'm feeling. Did you experience that? Like, okay, maybe I got every piece, and then you go in with the camera and you're like, oh my gosh, there's something there.
I did, yes. And it was a very humbling experience. So, my mentor, as mentioned, she mentored me in hygiene school. And I even did my table clinic as a senior in hygiene school on the endoscope because I was even like interested in it then. I I competed nationally at the ADHA back in 2016 with the endoscope topic. But I kept just bothering her since I graduated. I want to learn. So she basically told me, "You need to walk before you run. I want you to get in there, get your time management, start doing your profis and maintenances in that 1 hour, get control of your instruments before you really get into this." So then I think it was like 6 months or so. Then I started getting trained on the endoscope. Once I started to get more advanced with the endoscope, I started treating some of my recares and maintenances, even though you couldn't even see the areas radiographically, the calculus, because some are buccal or distal lingual. So you won't be able to see that on a radiograph or if the calculus is veneered and flat. So even though I was being diligent, using all my tools, risk assessment, and taking post radiographs to make sure I got it all, there was stuff there. And it was a very humbling experience because we can be the best clinician we can be, but there's even world renowned periodontists that say that we do miss calculus unintentionally. It's out of our control, but we do the best we can. And of course, getting in there and actually debriding that root surface will help the patient and make them better than they were. But if there's still residual, that localized site may not be healing the way we want it to.
Even in X-rays, I mean, it takes so much for it to show up on an X-ray.
Yeah.
It's not the best tool. Like we've all had those patients that come in and there's no radiographic calculus, but then you get in there and there's calculus literally everywhere, and it's like shocking that it's not on the radiograph. I think for me too, like even with biofilm, practicing with the airflow and using GBT, I was humbled about how much
Mhm.
biofilm I was leaving behind, because putting on that disclosing solution, I would think I'm done. And then I'm like, okay, let me go check all the distal surfaces with my mirror. And I would see distal surfaces on the upper left. And I'm like, oh my
That's my
gosh.
my dreaded quadrant too. Ugh, upper
Oh,
left.
the upper left. I hate the I hate the
Same.
upper left.
I'm always like,
I'm like, oh.
even with my endoscope, I'm like, ugh.
Yeah, it's number 14, 14
Yes.
distal for me. Oh, I hate that one, but I'll try
Yeah.
my, I do my best, but that one ergonomically is a rough time for me too. But it's really inspiring to hear your story and how you start and you kind of build upon that. And now, you have this amazing role that not a lot of us hygienists are in yet, but hopefully this will inspire them to learn more about this technology. And I think just like moving forward and thinking about hygienists advancing in our profession, this is one of the ways that we can do that, like using all of this new technology and really getting into perio and prevention. What's the title you gave yourself for going into the offices?
So we even have our cute jackets that we created with our company, Perio Precise, and we put Perio Endoscope Specialists.
Perio
So
Endoscope Specialist.
so we are the specialist, the mobile specialty hygienist. So we are the Perio hygiene girls on wheels.
So cute. I love it. Do you have any additional information that you would like to share for everybody that's listening, and anything else about the endoscope?
I would say that we are having a really hard time in dental hygiene right now. I'm president elect for Nevada. This year we fought really hard. They're trying to regulate us. And I would say this is the time to really start learning skills that an assistant may not be able to do. And I'm actually writing the bylaws right now for the endoscope. It's a procedure that helps prevent surgery. So in essence, this should be a specialty. Now that there's so many hygienists that are myofunctional hygienist, and that's a specialty. I do believe that this could also be a specialty. So, right now is really the time to level up your skills, set yourself apart, that we are a true healthcare provider and showing the knowledge and power that we do have and how we can really help our patients in that preventative way. So, if you did have the opportunity to learn this skill or any other type of skill that can set you apart, I would highly recommend to do so.
Oh, it's such a great topic for us to talk about, because I know you're very heavily involved in all of that. And I've had students reach out to me and they're in school right now and they're like, oh, we're hearing about dental assistant scaling, and should we still become hygienists? And to that, I say, is that all you're doing is scaling teeth? Like, if that's all you're doing as a hygienist, then yes, be concerned that your job will be taken away from you. But that's the time that you need to reevaluate like what you're doing as a hygienist. And like you said, start doing these things that set you apart. Start learning about the airflow, GBT, the endoscope, administering Botox and filler, and start utilizing all these strong skills that we have and advance our profession and practice at the top of your scope in order to really feel confident in what you do and not be afraid that this is going to take your career away from you, because ultimately that's not the only thing that we do. We don't just scale teeth.
Even when you take it upon yourself to learn a new skill, just as I did, and now I'm partnering with dentists. Dentists are actually hiring a hygienist to come in and they're trusting us. It's a different level of respect also, because you're in there partnering with them side to side collaboration versus what's going on in the country right now. And we don't want to make it a dental against hygiene battle either. We're all in this together to provide the best care we can to all of our patients.
Absolutely. Well, thank you so much, Marvelyn, for sharing all of your amazing information. I got to get my hands on one of these. I
Come
gotta
on
do
to
it.
Vegas. You're right next door. Come on over.
I am definitely going to explore all of the things because do you do CEs on it by any
We
chance?
do. So
Okay.
we do plenty of CEs. We've done webinars. We go to different hygiene associations. We're doing all of that. I really hope for the future that there is a smaller endoscope that can potentially come out at the fraction of the cost that will be readily available to all of us to have in our operatory. Because what I see happening is if we can have it small enough to be in everybody's operatory on maybe an iPad or something like that, we can even do it on Profies. Why not even do it for preventative care if we have the ability to do that? So that is my vision for this, and hopefully we can have something like that come out that will help all of us.
That would be so cool. I'm like, I would add that to the list of, like,
I
things
know.
that I wanna do, like, I love it. Well, thank you so much, and I'll
Thank
leave all
you.
of your, information in the show notes of this episode, where to contact you and more information about the Perio Endoscope, and yeah, thank you for being here today.
Thank you so much for having me, and I appreciate everything you're doing for the hygiene community. Also, keep up the great work.
Thank you. All right, everybody, until next time, this is the Brush with Brit podcast.